Hi, everyone. My name is Jen Braun, and I direct the AHA Team Training Program. Welcome to today's sponsored webinar, Onboarding and Professional Development, Assessing and Addressing DEI. We're extremely honored to have Relias sponsor and lead this presentation and discussion today. They've been a great partner for the AHA and really appreciate their leadership and work they've done in this really important area. But before we get started, just a few rules of engagement to highlight. You can access audio by listening in through your computer speakers or through your phone. Please note that you're in a listen-only mode. If you're having any issues, you should be able to access the toolbar at the bottom to switch to either phone audio or computer audio. This webinar is being recorded and will be made available on our website, and we'll notify everyone who signed up once it's up and loaded for you to share with others. We've shared the slides via email prior to this webinar, and my colleague Kara will chat the slides in again as well. And so throughout the webinar, if you have any questions for our speakers, please enter them in the Q&A pod. So the Q&A pod at the bottom of your screen. I'll do a moderated Q&A session at the end with our panelists. If you have any technical questions or comments in general, feel free to use the chat pod. Please note that all participants on the webinar can view the chat pod, and it will not be included in the recording. Finally, after our webinar is over today, we'll have an evaluation that will pop up in your browser, and we really value and appreciate your feedback. So please take a moment to complete that. And so we have three fantastic speakers today. Felicia Sadler, who's the VP of Quality at Relias. Felicia is a partner of Acute Solutions, and she's been a registered nurse now for over 35 years and has served in various nursing leadership roles. She's a certified professional in healthcare quality, a Lean Six Sigma Black Belt in healthcare, and has served an examiner for the Tennessee Center for Performance Excellence. Laura Sparkman is a partner of Clinical Solutions, Patient Safety and Quality, also from Relias. And she provides both internal and external consulting, thought leadership, and strategic guidance on the use and optimization of Relias clinical solutions related to improving patient safety and creating high reliability in some of the highest risk areas in healthcare, such as obstetrics and emergency department, as well as other clinical areas within the acute setting. And finally, last but not least, we have Mirta DeVolt, who is a senior program manager within Providence's Nursing Institute and Clinical Academy. She currently leads the development, maintenance, and implementation of transition into practice curricula for a multi-state system in obstetrics, neonatal, peds, and nursing professional development. And before moving into nursing education, Mirta spent 6 years as an OB nurse and is really passionate about improving nursing education with the goal of providing the foundation and support for nurses to deliver the best care for her patients. So as you can see, we have a stellar lineup of speakers today. So with that, I'm going to hand things over to Laura from Relias to kick us off. Laura?
Thank you very much, Jen, and thank you everybody for joining us today. I just wanted to kind of run through what we're going to talk about today. We've already done the introductions, so you know us. We're going to talk a little bit about CMS and the National Patient Safety Steering Committee highlights that became effective and ratified in October of 2022 for 2023 on the inpatient prospective payment system rules, because that kind of governs what hospitals are focused on nationally. We're going to talk about some onboarding strategies, and then diversity, equity, and inclusion and onboarding education and what that looks like. Just a few moments to talk about who Relias is. One of the things, and again, Felicia and I are part of the Relias team. Mirta is actually one of our clients, and her system, Providence, has been part of Relias for many, many, many years. So we're thrilled and honored to have Mirta with us. But one of the things that we do at Relias and what brings us passion is really our mission, and it's true, and that is to measurably improve the lives of the most vulnerable members of society and those that care for them. And that's what makes us get up every day and want to keep, I call it fighting the good fight around improvement, safety, just and equitable care. And that's at the heart of the work that we do. Relias, again, we're a very large education solution technology company. We have over 11,000 healthcare and human service customers, 9,000 available and maintained courses, a very sophisticated learning and education platform, and over 1,000 years of experience on staff. And I'm obviously one of those old people who add many years to that list of 1,000 years of experience. But again, just a few examples of our partners: A1, Healthcare Technology Company, Providence, Common Spirit, Mercy, etc., American Hospital Association, ANCC, just to name a few. Again, we're talking about DEI today and onboarding and psychological safety, workforce safety, and some of the biggest issues in healthcare. And Relias is actually broader in terms of our content offerings. We're very focused on retaining staff, elevating quality, reducing risk, improving patient safety, and reducing harm. Many of our education contents we fit in the solutions and performance. So we're trying to improve things like nurse turnover, mortality, maternal mortality, bringing in the right talent and placing them in the right organization for your success and for their success. In addition, we've developed compliance management, recruiting, staffing, and we go across the continuum of care. So just very high level, a few bullet points on who Relias is. So we want to get into the meat of what we're talking about today. And we're going to start with a poll. So very quickly, what are the most impactful changes made to the Medicare inpatient prospective payment system that affect our clients and prospects in acute care hospitals in 2023? So really, I would just say that affect healthcare. Is it A, health equity, B, birthing friendly designation, hospital acquired conditions and reporting, including healthcare associated infections, $2.6 billion increase in hospital reimbursement, E, all of the above, or F, just A and D? So this is a poll. You had a pop-up screen come up, and if you can answer that poll, we will reveal our answer. So I know, Carrie, you're calculating that in the background, and we're just waiting for your cues before we move on.
Yes, we'll give everyone about 10 more seconds to get their answers in. Okay, we have the majority, 54% say all of the above, and 30% are saying health equity and the 2.6 billion. And the answer is all of the above, E. So it was a tremendous year of massive collaboration and sweeping changes at the Center for Medicare and Medicaid Services. It was a 25-year all-time high payment increase. That was a large push from the demands of hospital workers coming out of COVID. Obviously, that was a big influence piece to that, and required reporting and participation in maternal mortality improvement programs around education and new birthing friendly designation. You'll see how we tie this into DEI and social determinants of health. That's obviously a big focus at the national federal level. Health equity and social drivers of health data submission are spotlighted.
Now more than ever, at the federal level, there's a push for more demographic data, including zip codes, because they really want to identify where areas of need and medical deserts exist, et cetera. And, this could be a burden for many hospitals, because, this requires staff and time and dollars to do this type of reporting, but it's obviously very important as we start to kind of unveil some of the challenges that we've been faced with and that COVID really spotlighted for us. In addition, 10 new hospital-acquired conditions, value-based payment incentives, some reporting is being suppressed, but data is still being collected. So CAUTI, CLABSI, falls, pressure ulcer, et cetera, all the things that are still very, very important for patient safety. Again, this is very important in my work and background and others around patient safety and improvement. I've been consulting in this space for well over 20 years, but COVID obviously really spotlighted the gaps in care and how much we've actually backslid in patient safety and high reliability. And 27 organizations and leaders came together to really complete and make a recommendation, design a recommendation around total system patient safety bundle and getting back to achieving zero harm in healthcare, and that it's essential for organizations to meaningful reset and advance safe, reliable, and equitable care to strengthen the resilience of systems. The 4 primary areas of concern that fell out in this work was workforce safety. None of this will be a surprise to you. Learning systems, patient and family engagement, culture, leadership, and governance. And then again, and this is not new news, but it is still very relevant. And we're still coming out of COVID. Things are somewhat starting to normalize, but we are still dealing with and building systems to sustain over time, right? What we don't want to do is create something temporary and then comes another event, a major event to the healthcare system, and we did not build in that resilience that we need to sustain that. Again, for workforce safety, I'm not going to read every single thing. You're going to have access to this, but again, you've heard about the burnout, depression, clinical depression. Surveys of nurses remain stressed almost 2 years into the pandemic, with 75% of nurses feeling stressed, 62 reporting feeling overwhelmed. Learning systems, hospital-acquired infection increased for 47% in central line bloodstream infections, 45% in ventilator-associated events, et cetera. And racial and ethnic subgroups experience a disproportionate higher percentage increase in deaths compared to their white counterparts. And then culture, leadership, and governance. I think what really sticks out to me here is that between February 2020, September 21, the healthcare industry lost 500,000 workers. And then in an assessment from HRQ of 160 hospitals, an alarming 40% reduction in staff perceptions that management made safety a priority from 2018 to 2020. So this is really even before COVID. Think about that. And then coming out of COVID, and now you can just, people threw up their hands and say, I can't do this anymore, or what are we going to do? And so I think that, we want to talk about that. Very quickly, I want to move through this. I'm not going to read all of this, but for each one of those 4 major areas of the safety bundle, culture, leadership, and governance, again, ensure safety is demonstrated as a core value. What does that actually mean? And we can't just give lip service to this. Leadership can't. They really need to implement. And that was the whole purpose of this group coming together, to re-energize and get back to that work that was very well underway. Same with patient and family engagement. Again, establish competencies
for all healthcare professionals for the engagement of patient, family, and care partners. And this is part of the inclusion component of how do we know how to get better? Who is the population that we're serving? What things do we need to do to modify the work that we're doing so we're not just rubber stamping everybody? We're not just in the electronic medical record checking the box on things, but we really understand our patient population, and we're uniquely designing our programs to meet that population. So super important to getting to that personalization of care. Workforce safety, again, I think all of this group that's on the call today, I saw the list. There's over 500 people joining us today, and so many nurses and leaders in healthcare. And so you all know this better than anybody, about what we're talking about, taking accountability for physical and psychological safety in the health work environment. And again, fosters joy and brings that back to work. When you have that, we know that's where people stay as part of it. And then again, learning systems. So with that, I'm going to turn it over to my colleague, Felicia, to talk about onboarding strategies.
Thank you so much, Laura. And thank you all for joining us today. When we look at or consider the U.S. General's framework, certainly they've recognized the workforce challenges really across industries and have developed this framework where safety and security are one of the 5 essentials. These essentials include a centeredness on the workforce voice and equity with a focus on protection from harm. So why is this important, and how can we as healthcare leaders promote and even provide this beginning in onboarding, day 1 of a new hire coming into an organization? In this particular section, we'll discuss a few approaches and strategies to be considered. When we think about the critical first steps, our next slide really highlights that alignment and considers the alignment of onboarding to an organization's mission, vision, and values. So if we can look at the next slide, we'll look at the key focus. When we think about the key focus on aligning onboarding to an organization's mission, vision, and values. And one of those key focal points is DEIA, diversity, equity, inclusion, and accessibility. This is critical to any onboarding program, and even an organization's core competency should also reflect this within the organization's infrastructure. This can serve as a foundational component or launching pad, if you will, of not only being proactive, but introducing core concepts, these core concepts in onboarding. It can also be foundational to any part or serving any part of a quality patient safety strategy, if you will. Really thinking proactively in the onboarding phase as we think about orienting and onboarding new hires. Preceptorships, mentorship programs can also support this well beyond the onboarding phase. And we'll cover these in a bit greater detail in a moment. When we think about belonging and connecting, our next slide really goes into those considerations around DEIA and our key elements. Connecting new hires with meaning and purpose is absolutely critical to the healthcare workforce. This was a crucial finding in the recent 2023 AHA workforce scan, assisting new hires with their why, their purpose, and guiding them on their desired career pathway, which certainly leads to improved nurse and patient satisfaction. Outlining critical success factors in a clinical pathway, if you will, and those workflows can really utilize or bring in those real-time metrics. And it allows organizations in onboarding to be transparent with those metrics, which is also essential when you think about belonging and connecting and including all that comes into an organization. The new hires really knowing and understanding the milestones that they need to achieve to be successful in onboarding is also another critical component, and where they need to be when it comes to a successful professional journey within an organization, which certainly lends to improved retention, nurse satisfaction, and really augments the overall success of the organization. Earlier, we highlighted the U.S. General's framework, and part of this framework is really addressing a basic human need, which is really to feel safe and secure. So when you think about psychological safety, organizations should be providing an environment where employees feel safe and they know that when they come into this organization, they will be safe and protected. Safe employees, when you have safe employees, there's a higher likelihood of actively participating in conversations, for example, contributing to performance improvement activities. There's an ability to, they feel enabled to provide a free flow of ideas without retribution. And certainly this all leads to innovation. In addition, they feel safe to report, with psychological safety, can feel safe to report concerns or events that certainly can help inform and promote high reliability principles. And really within a high reliability organization can absolutely lend to the effectiveness thereof. When we think about psychological safety for all, it's really that all can be safe without retribution or judgment, with the ultimate benefit being that the patients we care for will be safer. As nurse leaders, we should role model transparency. When we think about that transparency process and onboarding with the metrics and the success, we should also lead with transparency and vulnerability and taking the lead to which begins certainly in the onboarding process. Earlier, Laura highlighted the National Patient Safety Steering Committee framework, which included workforce safety. So we know that there is a psychological safety component in workforce safety, and there's also a physical safety component. And these are critical elements in an organization committed to belonging and inclusion. Thinking about providing choice and autonomy with participatory engagement is another component that can be gained through a personalized onboarding experience, as well as ongoing professional development and growth within an organization. So new hires coming into an organization should be fully aware and certainly plugged in to all of these opportunities so they can feel like they're already a part of the team day one and they feel welcomed and included at every point. But they also need to see that well beyond onboarding within the organization. And that goes back to the mission, vision, and values of the organization. So when we look at onboarding considerations, certainly including core DEI training is a key component. And I think our next slide will highlight that. Really including that core DEI training for all new hires so that you can begin to acclimate everyone that comes into the organization to your mission, vision, and values from day one. We know the impact on patient safety. We know the need for safe reporting structures. And it just makes total and complete sense to include DEI as part of that so that you have a culture of safety, if you will. This too should also be part of, again, any proactive risk management program as well. So this can actually feed into your risk management initiatives. Thinking about mentoring and coaching and really that belonging, going back to that belonging and connecting, mentoring and coaching can be an absolute phenomenal way and should be considered as an ongoing commitment well beyond onboarding. So plugging them into that and so that you pair them up with those who can show them the way to be successful in the way within the organization to support any desires and goals that they may have in their careers. So consider establishing that as well as a process for intentional follow-ups that go, again, well beyond onboarding. So once they've completed their onboarding phase, certainly ensuring that you build in intentional moments and intentional opportunities to check back in with them along the way in their journey within the organization. While these are only a few general considerations, they are vital and can lend to a positive experience for you all, for the organization, for the teams, also for the new hires within your organization to be successful. I'll now hand it over to Mirta, who can discuss her journey and strategies to a successful onboarding program at Providence.
Thanks, Felicia. So Felicia made some excellent points about the key components for an onboarding program. And I'm just going to narrow the focus in a little bit on our onboarding program in obstetrics and give you an example of how we have tried to answer some of the call to action around diversity, equity, and inclusion, while also creating that psychologically safe space for our new nurses to explore these topics. So before I dive into it, a little bit about our organization. We are across 7 states on the West Coast. You can see on the map here. We have 44 obstetric units within our 52 hospitals in the organization. And to give you an idea of the scale of our onboarding program, we have onboarded a little over 1,800 obstetric residents, which are new graduate nurses, and fellows. Those are nurses that are experienced, but in another specialty and transitioning into obstetrics as their new specialty. This is since 2016. In the last 6 months, we've onboarded about 250 residents and fellows. And so we have quite a large program. And Laura, if you want to move to the next. This, as Felicia was emphasizing, it's so critical to connect your employees to the organization's mission, vision, and values. And for us, we also have a promise. And you can see them here. We are a large Catholic organization, so our mission is to be steadfast in serving all, especially those who are poor and vulnerable. And our promise is to know me, care for me, and ease my way. And I see that, being an educator myself, I see that not just as a promise to our patients, but also as a promise to our employees and especially our new nurses as they're coming into our organization. And one part of our strategic plan that was published recently is a pledge to address diversity, equity, and inclusion and accessibility in our organization. And you can see the components of our pledge here. Our team that has developed and maintained our obstetric curriculum for onboarding has really paid close attention to this pledge, and we wanted to make sure that we were bearing this out in the curriculum that we were presenting to our new nurses. And so we took this pledge, and if we move to the next slide, I can show you how we've condensed this down into some specific goals for our program. We wanted to make sure that we were increasing our diversity representation in our program through images, language, the way that we describe case studies, things of that nature. We wanted to make sure that we were aligning our language with best practice, addressing implicit biases and the influences on care. Beyond a 30-minute module that our organization does require of all employees, we wanted to really dig into these topics, allow space for personal reflection, and thinking about how each individual nurse has an impact in this area. Through this, we're hoping to build a culture of empathy, respect, and compassion, and create a safe and inclusive space for all caregivers and patients. So starting with the first step, language really matters. And so we did a lot of changing of our language that we use in our obstetric curriculum, beginning with what we called ourselves. So we formerly were the Women and Children's Clinical Academy. We have language within our healthcare system that we knew we had to replace with more equitable language. And so you can see the old language here on this slide. And as we move to the next slide, you can see our new language. So we are now calling ourselves the Obstetric Neonatal and Children Clinical Academy. We want to make sure to use substance use disorder, describe our patients with limited English proficiency, be sure that we're referring to our patients as pregnant people or the birthing person, and call out that our inequalities are due to racism and systematic oppression. So looking at a little more specifically how we have integrated this into our curriculum, I'm going to give you a little snapshot of some components of our onboarding education. And so we'll start with taking a look at the modules that we include in our curriculum. 2 of them come from Relias. As soon as Relias published these first 2 modules you see on the list here, we were very intentional about including them as a required part of our onboarding education. We also created 2 additional modules that we have uploaded into the Relias platform and also require. And you can see those there. We split them into 2 parts, and I'm going to show you a little more specifics about those 2 modules. So if we can go to the next slide. Oh, first, I would like to ask you guys how you are currently introducing DEI content to your new nurses. So this is a select all that apply Just curious where everybody's at in their journey, in their organization.
Responses are coming in, and we'll give people about 20 more seconds or so to respond to this one.
Great. So I think many are, I would be surprised if there wasn't a majority doing some sort of online module. And curious about all the other components as well. Great. Okay. So, yep, as I suspected, the majority of responses doing modules. I'm loving that there's a good portion of you all also including class activities and changing your educational content to be more inclusive. That's fantastic. So let's take a look at the next slide here. I have one more poll for you. So there's lots of resources out there. Since I'm describing our obstetric content in particular, I'm wondering if anybody is using the A1 SBARS for inclusive and equitable patient care, perhaps the CDC's resources, the AHA's resources, or maybe something else.
We'll take a few more seconds to wrap up this poll.
Thank you, Kara. All right, excellent. So I hope that those of you that marked that you haven't heard of these resources, I hope this is an opportunity for you to look into those after this presentation and really explore what's being put out there so that you don't have to start from scratch. There's some great stuff. Okay, so looking a little closer at this module that we've created, we have taken A1's SBARS for inclusive and equitable care, and we have turned them into a module. So we've focused on the 4 different SBARS they present, one for Black patients, one for patients in the LGBTQIA+ community, patients with limited English proficiency, and patients with substance use disorder, and use those as opportunities to prompt our learners into some personal reflection. And so, Laura, if you want to go ahead and send us to the next section, you can see an example here. Part 1 just focuses on these 2 patient populations. And if you click on one of those within the module, go ahead, Laura, it'll take you to the first part. So we present our learners with a situation in the background that again comes from the A1 SBARS. After this, there's a video that we have a person from the population being focused on sharing their perspective and experience receiving healthcare. And then there's a reflection question that learners are able to anonymously answer, asking if they have any personal biases against individuals in this population group and what actions they might take to help that particular person and their partner feel heard and understood. After they complete that, then the next step is to see what the assessment, the recommendations, and the follow-up actions from A1 are suggested from best practice. After they complete these modules, then they go on to participate in some in-class activities, which we'll take a look at next. So we give our learners an opportunity to watch a video on implicit bias, which we're going to take a look at in a moment. They will complete an anonymous quiz on perinatal perspectives and biases. They also have an opportunity to take the IAT, which is an implicit bias personal assessment from Project Implicit. And if you have not heard of that, that's great work coming out of Harvard. Really has a lot of opportunity to just start people on the journey of recognizing what their own personal biases may be. And then we have opportunities to discuss as a group. And if we move to the next slide, you can see the in-class activities in a little bit closer focus. So there is this quiz, again, very anonymous. We want this to be an opportunity for personal reflection. And then next is their perinatal perspectives worksheet. And you can see the types of reflection questions that we prompt our learners with here. So next, we'll take a look at how we are creating psychological safety for our learners.
As caregivers, we have the unique opportunity to work intimately with people from all different walks of life. While we work to connect with and find commonalities between ourselves and those we care for, it is likely that we can also identify noticeable differences. Some differences that we may have biases about. We already know that bias is part of being human. We also know that negative biases that we have about any one person or group of people is often a result of complex social factors. Most importantly, we know that biases, when left unchecked, have the potential to impact our perceptions of and interactions with people. And the critical first step to stopping bias from influencing our behavior and actions is to reflect and create awareness for the biases that we have. We have already had the opportunity to explore our biases surrounding patient care within our nursing specialty. Another critical step is to reflect and bring awareness to biases we have about people that are members of historically marginalized communities.
So that was just a short clip of how we introduce the concept of delving into these really challenging topics for people to explore their own biases. We want to set the stage that this is not something that is intended to produce guilt in any of our learners, but this is just something that we need to raise our awareness around so that we can continue to move forward and start to make some actionable change. And so when we are thinking about creating that psychological safety, those safe spaces for our learners, we set the foundation in this way. And then if we move on to the next slide, I can show you other ways that we embed self-care and psychological safety into our classroom. So we have our learners engage in self-care and compassion activities. Here's an example of how we may end one of our classes and having them complete a self-care and compassion activity of their choice. And if we move to the next slide, you can see some examples of how that plays out. So there's just some reflective scenarios. Learners can often find themselves in similar situations on the floor. I wanted to give you some examples of how we integrate this into our classroom so that we make sure that we're keeping the well-being of our caregivers at the forefront, even as they're going through the stressful experience of becoming a new nurse or onboarding into a new specialty. And then, as I'm sure you guys are thinking, this is really heavy topics for us to delve into with our new nurses. We had the same thought and knew that in order for our educators to feel psychologically safe and prepared, and be able to make these discussions meaningful within their classroom spaces, we needed to make sure that our educators were well prepared. And so before we launch any of the changes to our curriculum integrating these practices, we have focused on training our educators and making sure that they feel comfortable engaging in these discussions in the classroom with new learners. And I love this quote by Altman and her colleagues. I would highly encourage you to read this entire article, but educators can most effectively help students understand and focus on positionality when they examine their own. And this example here from Brown is how you can start looking at your own positionality in relation to some of the topics around DEI before you start leading the discussion with others. And so the way that we chose to develop our educators is by using a learning circles teaching methodology. So I'm curious from the audience if you all are aware of this. Have you heard of it before? Is this something you're using? Should be just a really quick poll here. Great. Oh, some of you are using it. Excellent. All right. So this, we'll move on to the next slide. I'll tell you a little bit about learning circles. It came out of the public library system. This is where it's been used most often in the past. It's a collaborative learning model. It's based on distributed leadership, so there's not one expert in the room. It's best done with a small number of participants, and it's usually linked to a theme. And the goal is to get a deeper knowledge and a shared understanding of the topic. Some of the benefits of learning circles are that it can positively impact a sense of belonging and psychological safety. If you want to go to the next slide, Laura, which really increases an impact in more than just the individual, but as the whole group. And then as this shared leadership model is enacted, you have both the learning of the topic and the learning of leadership and facilitation skills kind of partner together as a dual outcome of this method. There is an emphasis on the development of empathy and critical thinking, problem solving, decision making throughout this process. And it really enhances this positive learning culture that we're trying to create in our organization. The components of the learning circle, you have a facilitator. There's obviously the other members of the learning circle. The meeting space can be in person or it can be virtual. We facilitate ours virtually only. The recurrence, it typically happens over time. So you'll focus in short periods of time, and then after a series of sessions, then you cover the entire topic. And there's often dedicated learning materials that go with the topic. And so I'll show you how these have played out for us, helping our educators be prepared to facilitate DEI conversations. So we have 6 learning circles. They're done every 2 weeks for 1 hour at a time. And you can see the topics here. So we focus just on getting comfortable with DEI, with your own positionality. We move on to looking at inclusive caring for all with an emphasis on resources internally and externally. Then we focus on creating a safe environment, dealing with conflict, and then addressing historically marginalized groups, and finally promoting and advocating for health equity, sort of next steps, moving beyond the learning from the learning circles. The structure of each 1 hour learning circle is as follows. So it starts with an icebreaker. We do a check-in and peer support. We have the specific activity, and we end with goal setting and doing plus deltas. And we created what we call recipe cards. And you can see an example of one of those recipe cards here on the slide. This is from the first learning circle around getting comfortable. Often there may be some asynchronous pre-learning prior to attending the learning circle, and you can see that outlined here. It's usually just an article or maybe a website to take a look at. So we have just launched, this is our first time doing our learning circles. We are finishing with our 6th learning circle in a week, next week. I wanted to share with you all how we're measuring the outcome of our learning circles. We're focusing on comfort and confidence with facilitating education around positionality and privilege and oppression. This is one question from our pre-assessment. You can see that the majority of our participants were somewhat uncomfortable or neutral in answering this question. We're going to ask it again. Hopefully we'll see a shift to the right here. This form, the link to the form, the QR code, they go to the same form, and it's for you to just see which questions we're focusing on. If you want to facilitate learning circles in your own organization and you're looking for a template, you can certainly use this form as an example or something to go on. And then finally, I really want to make sure that I acknowledge the rest of my team. So Kinsey and April have been extremely instrumental in creating this content and supporting the efforts that we're making in our organization to include both the DEI content in our obstetric curriculum, as well as creating that psychologically safe space for our learners and our educators. And again, as Felicia mentioned, we are focused on that onboarding education, but also that continuing professional development for our educators as they're learning new skills themselves. And that is it for me. I appreciate everybody's attention. I'm looking forward to your questions.
Thank you, Merita and Felicia. And then we'll hear from Jen.
Yeah, thank you so much, ladies, for the really great overview and the specifics of the program you've developed and the education you've provided. We've had a few questions, so I'm going to I'll start broadly here. One of the questions that was chatted in is when folks are thinking about their plan for DE&I education, what Mirta, did you kind of take into consideration through the onboarding process in terms of priorities or how you plug DEI into other aspects like compliance and continuing education?
Yeah, so I'll try to answer that. My focus is specifically on onboarding. So my team does not do compliance education, nor do we do a lot of ongoing education for nursing. However, given the influence that we have over our educators within our system who do play a very large role in both of those areas, I think that we're going to see a huge ripple effect of taking the example that we're setting by showing how we can integrate this content into our onboarding education, how we're creating a really confident pool of educators in facilitating conversations around DEI, and then move that into some of those other areas.
Yeah. And can you tell us about that decision point or what you took into consideration for developing like new approaches to DEI versus kind of integrating into already developed resources and education?
Yeah. So it was important for us to acknowledge that to do this journey of self-reflection and looking at how your implicit biases may be impacting your patient's care, it's really well described in the literature that this is a problem. And there's lots of pathways for how you can move down that journey and impact patient outcomes in the long run. I think for us, starting at the beginning and making sure that we were not just asking people to complete the module, but also layering on top of that, again, that opportunity for discussion and reflection and thinking about, what does this mean to me personally? What does this mean to my patients and each of my interactions with my patients? How am I playing a role in the team? How am I influencing what we're looking at in terms of our data on the unit, how we're writing our policies, things of that nature. And so we felt like it was important to structure an educational program that was beyond what the minimal requirement was for the organization.
Got it. Kind of taking a broader view on DEI, and I'll open this to maybe all panelists, because Mirta, I know you're definitely focused on the staff side of things, but does anyone have any experience promoting DEI among patients who may have expressed biases towards staff?
One of the ways I want to say, how we think about it, particularly if we're, maternal mortality crisis, which is very much a national focus. And we know that Black women die, 3 times higher than white women. But one of the things that we've often said, part of it is variation in the way the care is delivered, and that people are making their own decisions and not necessarily following the national evidence-based guidelines, or they lack knowledge of the national evidence-based guidelines. So a philosophy I think that we have is that if you're following protocols and the national evidence-based guidelines, you're not, some of that racism is just not there, because it's it's the national evidence-based guidelines for any patient that walks in your door. So anyway, from an education perspective and a content perspective, however, I love the way that Myrta, they went back and they reevaluated their Providence organization, even in their language, to be more inclusive and aware of things we do. And Myrta and I have even had conversations about it. Like I had to, check myself about like, moms and mothers, and it's birthing people. And so I'm like, okay, I could do this. But again, I mean, that's just being vulnerable, right? That's part of the vulnerability around it. But I think one of the other things I wanted to mention is I think you do have to, because, if you go back to the comments that I made in the very beginning around the National Patient Safety System-Wide Safety Bundle, equity, inclusion, and DEI, social determinants of health, we really do have to evaluate and do a gap analysis of all of our protocols and procedures and make sure that we're being mindful of modifications and tweaks that we have to make in our everyday processes. And I think that's, an important kind of takeaway around that. Felicia or Myrta, anything else?
This is Felicia. I definitely agree. And just to take that a step further, thinking about, studying your patient populations and incorporating that into the patient populations that you serve in your communities can also be another layer to be helpful to make sure that, again, this is a journey. We're on a journey. And so, it's not necessarily going to happen overnight, although I think that we've done and put in a lot of structures and processes to expedite so that we can get there. And it's really just the speed to get there so that we ensure that we're positively impacting those patient outcomes as it relates to our patient populations.
Exactly. There are a few questions regarding tools and whatnot. And I know Myrta chatted in the project implicit IAT link to everyone in the chat, but I don't know if you all can speak to any of the resources or tools here and how to access them or get in touch with you if folks are interested.
So the video that I shared with you, the short video clip, that was one that we created internally. Mm-hmm. Again, as Jen said, I put the project implicit link to the implicit association test in the chat. And then the module that we created was created directly from AWAN's SBARS. And so that content can be found on AWAN's organization site and is available to everybody for educational purposes. I think Laura can address the other two modules that we use in our program, which are part of the Relias program.
Yeah, I mean, it is, Relias developed content. We actually develop all of our own content in-house. It's not necessarily where, we're taking third-party content and just sitting it on the platform. We develop 99.9% of all of our content. So, and if anybody is interested in the social determinants or the implicit bias course, we're happy to follow up with you directly on that.
Great, thanks. We'll share a follow-up email. So if folks are interested, we can make sure that they get in touch with you, Laura. And so I think the final question that's left is, I know it might be a bit early, Myrta, but any metrics on recruitment or retention as a result of this program, or just anecdotal feedback so far from new hires in this onboarding experience?
So we have a lot of metrics that measure our the outcomes of our onboarding program that I would be happy to share with anybody that's interested. But one of the two main metrics that we follow is obviously our first year turnover rates, which we've been able to demonstrate since the inception of the clinical academy that we are maintaining first year turnover rate significantly below nursing outside of our program. As well as looking at the Casey Fink, which is just measuring the experience of residents. This is a validated tool that's pretty well known if you're running a residency program. And again, we look, two main things that I really look at is our confidence of our residents over time. Actually, it measures lack of confidence, and then fear. We're looking for those things to decrease. And specifically, the fear question is asking around patient safety. And we're able to see those two things decreasing over the first year for our residents as well, which is telling us we're on the right track. As far as measuring metrics for if we're preparing our educators well to facilitate this content, DEI related conversations, we are getting a lot of really positive feedback from the pilot program that we've been running. Lots of encouragement to make this widely available to all of our educators outside of just the OB specialty, which we are planning to do as an organization.
That's excellent. I think we'll end on that positive, those positive outcomes and takeaways from this. So I just want to say, Mirta, Laura, and Felicia, thank you so much for your presentation today and your insights. We really, really appreciate your time here. So with that, I'm going to close out today's webinar. Please note that we will send a follow-up email with some of these resources along with notification once the recording is available on our website. And please note that once we close out today's webinar, an evaluation will appear on your browser. So if you could just take 30 seconds to fill that out, we would really appreciate that. So with that, I hope everyone has a great rest of your day and a wonderful upcoming holiday weekend. So thank you.